Good evening, everyone. I hope you can hear me. Please type that you can hear me in the chat section so we know that everything is fine. Welcome to Egg Donation Friends and IVF webinar. I'm your host. I'm Sophie, and this is my first webinar as a host, so please keep fingers crossed. And most importantly, our speaker today is Dr. Natalia Schlarb. She is medical director at IVF Spain, Alicante. And Dr. Natalia is a great speaker, and today she will dive into the topic of oocyte quality and important factors to think about after failed IVF. Dr. Natalia's presentation will take about 30 minutes. And then right after, we will start with the Q&A session. Dr. Natalia will answer all the questions one by one. So if you want to ask a question, just type all the questions in the chat section. You can do it already now. And just a short reminder that this webinar is being recorded and you can watch it tomorrow on our website, of course, if you'd like. Within a few days, we will also publish the transcript with all the Q&As section. And from me, for now, that's all. And if Dr. Natalia is ready, we can start the presentation. Dr. Natalia?
Thank you very much, Sophie, for great introduction. I keep my fingers crossed for us today. We are a good team. We're going to make it happen, and we're going to do our best for our patients.
Of course.
So today we are discuss the egg quality as a factor to think about after failed IVF. So this is something that I always show at the beginning of probably all my presentations, that we women, European, modern, independent, we study, we grow our careers, and we think about family quite late. So this what our moms have done before they were having children in their early 30s, mid 20s. This is not seem to occur in Europe anymore. We study, we take birth control pills, we fight a lot for our independence, but we have to be aware that our biological clock is the same as it used to be 100 years ago. Our biological clock is not aware of our careers, of our birth control pills, of our professional plans and business plans. Our professional clock wants us to have a first child before we are 30, 35 years old. And this is the problem that we are facing here in Europe. When we take a look at this slide, we see that women do not only plan their children too late when the egg quality is lower, that it usually is before 35 years old. What we see is that European women are getting less number of children during their lifetime. So average German lady gets what, 1.5 child statistically during her lifetime. A lady from France received not even 2 children statistically in her lifetime. When I saw the statistics, I was shocked because British statistic was not available. So the problem that we have is that later on in our life, after 35 years old, we realize that something is not working, and then after 1 year of trying without success, the patient is getting the diagnosis of infertility, and then patient comes to a specialist for reproductive medicine. We have to be aware that different European countries have different laws regarding this, what insurance companies are paying in their infertility treatments. In many countries, still inseminations, IUIs, are paid by the insurance companies. In IVF Spain, we do not perform this kind of cycles anymore because the pregnancy rates with IUIs are very low, are lower than 15% per cycle. But we have to be aware that if insurance company pays for 2, 3 this kind of procedures, we are basically losing our time and money. When the IUIs are done, then we plan IVF cycles, and then average lady between 35, 39 years old in Spain receives through insurance covered 3 IVF cycles. And usually this kind of cycles are performed with day 3 embryos or fresh cycles. So the pregnancy rates are also low. When we see ladies that are over 40 years old, average European lady receives 2 cycles over 40 years old. So we have to be aware that why shall we plan all these cycles in our life? Why shouldn't we think about having children earlier as it used to be 100 years ago? So in order to avoid a poor quality of eggs, we should recommend our nieces or our children in the future, our friends that are under 35 years old, that they should freeze their eggs so they can be their own donors in the future. So if this is not available anymore, we have to be aware that we women, we are designed to have children with our own eggs until 36 years old, and then our fertility drops down dramatically. So at the age of 46, 48, it's almost impossible to be pregnant with our own eggs. On the other hand, the pregnancy rate through egg donation are age independent. Before we discuss egg donation, where the egg quality is superb because Spanish donors are young, are fertile, we have to consider treatment when social freezing in our life has not been performed. We should consider a treatment with our own eggs, but putting a little bit of technology, this increases our pregnancy rates. So we have to be aware that when we are born, we have a certain amount of eggs, a certain quality of eggs in our ovaries. And as the time goes by, as all the environmental factors influence our eggs, their quality goes down. So we see here the number of genetically abnormal eggs that we generate. So the older we are getting, the higher number of genetically abnormal embryos we are generating. And with this genetically abnormal eggs, our pregnancy rate, of course, comes down. The question is, shall we do something to increase these pregnancy rates? What medicine has to offer me that my fertility due to my eggs quality does not drop so dramatically? So the answer is yes, medicine has something to offer for us. And this offer is the genetical testing of our embryos. So when we find genetically normal embryos after 12-ectoderm biopsy, after embryo selection, day 5 blastocyst sampling of somebody older than 35 years old. So with this genetically normal embryos, we bring you to pregnancy rates of somebody who is 30 years old or somebody who can potentially be your donor. So again, we see the older we are getting, the higher number of genetically abnormal embryos we are generating, but we are not going to cry about it. We are going to find a proper specialist who will support us, who will have a proper lab with the possibility of embryos biopsying. So we see here that the age groups and the number of embryos that we generate. So egg donors generate 60% of all the embryos, which are good. We have a good quality. We speak honestly with each other. The genetically normal embryos are checked for number of chromosomes. So we do everything through technology. We use a new generation sequencing technology that allows us to examine all the chromosomes, not only the most commonly affected due to our age with the trisomies, but all the chromosomes. When 10 years ago, when I started working in reproductive medicine, we were doing genetical testing, which was less comprehensive. We were examining the most commonly affected chromosomes for trisomy 21, Edwards syndrome, trisomy 18, and Pato 13, trisomy 21, the most common, the Down syndrome. Now, medicine has gone that far that we understand that we examine all the chromosomes from 1 to 46. And when we work so specifically with each other, we see that even though donors are young, only 60% of embryos that they generate are good, are healthy. Ladies that are under 35 years old have about 50% of embryos which are good. Ladies between 35 37 years old have 44% of embryos which are good, 38 40 33%, 41 42 17, and at the age of 42 or more, just 10% of our embryos are good. So statistically, when somebody is older than 42 years old, we need 20 eggs out of you, 10 blastocysts, and then one of them is genetically normal. We know that to fulfill the statistics, it's almost impossible at the age of 42, 43. So this is the age where we start canceling patients for egg donation. So when we see the pregnancy rates without genetics, with our own eggs of ladies which are older than 35 years old, we see that pregnancy rates are lower than 20% in IVF Spain. So we do not recommend for patients cycles with own eggs and no genetical testing. So from 35 years onwards, we recommend a genetical testing of embryos. It has to be an obvious for us. It's not going to PGS. It's not going to improve our eggs quality. It's just the methodology that allows us to select the good embryos, and either our embryos at this age between 35 42 are able to reach the blastocyst stage or not. If embryos are not developing to the blastocyst stage in two cycles where we use different protocol, we are honest with patients in IVF Spain, and then we recommend them egg donation. When we see that there are genetically normal embryos, the pregnancy rate per transfer is over 70%. If we find 3 such embryos, the pregnancy rate is 90% per cycle. So through PGS, we defined genetically normal embryos, and we bring you to pregnancy rate of donors, of somebody who is 30 years old. But you have to have certain number of eggs. You have to be able to develop them to the blastocyst stage. The blastocyst has to have enough good quality to be able to be biopsied, to be able to perform the trophectoderm biopsy. Of course, you need a team of embryologists that are specialized in embryos biopsying. We have 4 senior embryologists that from early in the morning until late at night, they just biopsy the embryos. So these criteria need to be fulfilled to talk about this pregnancy rates. So when we see that due to your age, we cannot develop blastocyst, or embryos are genetically abnormal, or there is no eggs, your AMH is too low. Some women come to us, and we always, on the day of first appointment, we examine your ovarian reserve, your age, your AMH, and ultra follicle count. When AMH is low and somebody is stubborn, wants to try with own eggs, of course, we tell your opinion that we prefer to perform egg donation. If patients do not listen and still want to try cycle with their own eggs, we support you with this kind of decisions just once, okay? And then if this is not working, if we see that during the IVF cycle you do not respond well, then we counsel you for egg donation, and then we do the program called Switch. We switch you immediately from IVF to egg donation cycle, so you do not have to travel back and forth. So in order to talk about certain quality of cycles, certain pregnancy rates, it has to be obvious to us that we have to develop embryos to the blastocyst stage. The embryos on day 3 of development are called morulas, have just 8 cells. Pregnancy rates with this kind of embryos are low, or under 20%. Day 5 embryos, if we do not use genetics of somebody who is under 35 years old, the pregnancy rates are about 60%. From 35 years onwards, between 35 42 years old, without genetics, pregnancy rates with blastocysts are lower, about 18%. If we select embryos, blastocysts, through genetical testing, the pregnancy rates are very high, at 70% per transfer. But you have to, your eggs, your body has to be able to develop embryos to the blastocyst stage. When I first came to IVF Spain, I had to get used to that in frozen cycles after genetical testing. We have higher success rates as in fresh cycles. It has to be obvious for us that PGS cycles are cycles where we have to use AMH dependent dose of hormones that allows us to reach 20-25 eggs per cycle and do not hyperstimulate a patient. You have to know how to do it. We use antagonist protocols. In IVF Spain, since I'm here 8 years now, I have not seen any hyperstimulation. When you generate so many eggs, you have to be aware that when you do egg collection with the needle, you can cause micro injuries of the ovaries. So also you have to, when you generate so many eggs, not only you have to be aware how to not hyperstimulate a patient, but also how not to cause a bleeding, because through the small holes that we have after egg retrievals, the blood can come out, and we can have hemoperitoneum, means we can have blood in the belly. So each patient in IVF Spain not only gets antagonist protocol, but also medication that improves blood clotting after egg retrieval, and touch wood, since last 3 years with this new protocol, we haven't had any complication. And the embryos are generated right away. We have fresh eggs of a patient. We fertilize fresh eggs with fresh sperm of a husband. If the sperm is quality is good, on the day of first appointment, the sperm is frozen. So we also work with the frozen sperm, and we have the same success rates with frozen good quality sperm as with fresh ones. Embryos are developed to day 5. So out of 16-20 eggs, I expect about 8-10 blastocysts, and then age dependent, we can have 1 embryo genetically normal of somebody who is 42 years old, 3 genetically normal embryos out of 10, yeah, of somebody who is 38, 40, 5 genetically normal embryos of somebody who is 35 years old. I like this kind of cycles where we have a patient 35 years old, good AMH, good X quality, and basically in one cycle generating 5 blastocysts, we can do entire family planning. Means egg quality is so good that we have 1 embryo to transfer a genetically normal euploid in the following cycle, and then we have at least 4 embryos frozen for second or third child if patient wants to. Of course, at the age of 40, 42, this kind of family planning is almost impossible, because we do not only have lower number of eggs, but we have lower quality of eggs, means we develop less number of genetically normal embryos. So for patients that have low ovarian reserve, AMH less than 2, older than 35. I always say between 35 and 40, if you have low ovarian reserve, if your AMH is less than 2, you always have to work double as much as somebody who has good AMH. It means you are not going to generate us 16-20 eggs, but let's say you're going to generate 8 eggs, and then out of 8 eggs, I have 3-4 blastocysts. Then in order to have you in pregnancy rates or be able to make family planning with you, you have to go back to IVF Spain 2-3 months later, where we repeat this kind of cycles, and then we do something called embryo banking. We bank embryos from 1 cycle, 2-3 months later, we bank more, and then eventually, even though you have AMH under 2, through the hard work, working double as hard as somebody who has good ovarian reserve, you are able to generate 6-8 blastocysts, and then we are able to find genetically normal embryos. The problem starts when AMH are low, are under 1. I had a patient today with AMH 0.06. So these are the results that allow us to counsel patients for egg donation. What I like about IVF Spain is the systematic work that patients are coming in the morning, one day, one patient, one problem. You have your blood drawn, and basically in the afternoon we have all the results, and then on one day we can offer you entire counseling, and after first appointment, where are you in your fertility, what can we do for you. So when some patients are coming and they still have hopes, and they believe it's still doable to work with their own eggs, but we examine you, we perform transvaginal scan, and the ovaries are empty. We do not see antral follicles. When we do AMH testing and AMH is low, we have to speak about egg donation, and it's a lot easier to counsel patients for egg donation, having all this information, all these documents, all these results on the table. So when we see that time went by and there is no eggs, or you show us in the history that eggs quality has been poor, that the blastocysts that you had in previous cycles in different clinics were C quality. So basically in Spain, our embryologists will not biopsy this kind of embryos. We know eggs quality is poor, and we have to speak about egg donation. So egg donation is the final step in the infertility treatment of many patients that we see in IVF Spain. We run now about 600 egg donation cycles a year. So we generate a psychological and physical mom and also genetical father. And after so many years of trying, it brings balance to families. But psychologically, we have to allow ourselves to accept egg donation. We will discuss the steps and the rules of egg donation in IVF Spain. So basically, when we have patients older than 42 years old, we see that out of 10 embryos, only one could be genetically normal. So you have to have a superb AFH, means you have to generate a lot of eggs to find one good one. Of course, we have 2-3 times a year cycles of somebody who is 42, 43 years old, where we have 2 eggs and 1 genetically normal embryo. So this kind of miracles happen. If somebody is stubborn, wants to try with own eggs, we will be more than happy to support you. But with genetics, we would like to know before we transfer your embryo if this embryo is healthy or not healthy. We transfer, of course, only healthy embryos. About mosaic embryos, I had a presentation a couple of weeks ago. Mosaic embryos means embryos which are a mixture of genetically normal and abnormal cells are transferred in IVF Spain. They are never transferred up front. These are the kind of embryos that we allow ourselves to transfer in the second, third attempt when all the genetically healthy embryos have been used. Of course, patients are signing with us special documents certifying that we recommend amniocentesis after transfer of mosaic embryos. Genetically abnormal embryos are not transferred in IVF Spain, even though patients, desire this. They say they don't mind. This is against our law to transfer genetically abnormal embryos. So here you see again, the older we are getting, the lower number of good embryos that we are generating. And then it's not only about number of genetically normal embryo, it's number of eggs. The older we're getting, the lower number of eggs we're generating, and then the lower number of genetically normal embryos we are generating. So at the age of 35, this is the moment where you shouldn't waste your time for inseminations. You should get a good cycle, good IVF cycle with genetical testing, because here still we can do family planning with you. Ideally is to perform social freezing at the age of 30 years old to have the best eggs quality. If this has not been done and time goes by, we see how hard it is at the age of 42 to find good embryos out of all our own eggs. And this is the moment where we have to think slowly about egg donation. So egg donation in Spain has certain rules. We have to be aware that egg donation in Spain is anonymous, means I can only tell you age and blood group of a donor when you are pregnant, nothing else. According to the Spanish law, we have to generate a child that will explain the combination of you and your husband and your egg donor and your husband. I always tell to patients that I have to find you a twin sister, somebody who looks like you, has the same color of hair, color of skin. So when we meet one day and your child will run around us, everybody has to think that you are a genetical mom. So in IVF Spain, we are blessed because basically the doctors that we have speak all European languages fluently. So we see patients from UK, from Germany, from France, from Russia, from Poland. So we have to be aware that we need donors for somebody with blonde hair, blue eyes, and we need donors for somebody with a background from India or a background from Asia. So the donors that we have are in 4 groups. Phenotype 1 are girls with blue eyes, phenotype 2 girls with green eyes, phenotype 3 brown, phenotype 4 girls from Asia and Africa. Many patients are asking us, where do we get these donors from? So we go regularly to universities in Alicante to speak to young students about social freezing. We teach them that they have to do their smear test regularly, that in a certain age the mammography has to be done. We teach young girls about safe sex, about condoms and birth control pills, how to use it, when to use it, how to protect yourself. And we teach them that they should have children before they are 35 years old. If not, we recommend them social freezing. A lot of those young ladies who perform social freezing in IVF Spain and decide to be our donors, they are offered the social freezing for free. And our students like it. And we also have a feeling that they can do something positive to help other women. So this is where we have our donors from. We have to be sure as doctors that the process is safe for you. Means the donors are examined before each cycle for infectious diseases, hepatitis B, C, HIV, syphilis. They are screened through a genetical testing that they are not carriers of genetical diseases like cystic fibrosis, muscle dystrophy. They are undergoing psychiatric examination, that they are not, that they do not have issues with schizophrenia, personality disorders, or major depression disorder. Of course, we perform drug screening tests. Drugs in IVF Spain are not allowed, not in any form. So this is the first step. In the second step, patients receive from us paperwork where they have to describe yourself, how tall are you, color of hair, color of skin. We ask you to send us your pictures. We are asking you personally what is important for you, which characteristic of yours your donor shall have. You have to choose from education, color of eyes, color of skin. We teach you if the blood matching with you and the donor should be performed or not. And we teach you how to speak to the child about egg donation. If you should communicate it to the child, when we teach you how to communicate it to the family. When this step is done, we put your data to the computer. Computer shows us 20 US donors available for you. And then all the doctors, we sit down together and we eventually decide who, in our opinion, is the best donor for you. So genetical matching, of course, we perform it when patients are carriers of certain diseases. We match your donor and your husband that they are not carriers of the same disease. So Not long ago, I had a patient from London with, I think, Jewish background. Cystic fibrosis came out of a husband, Wilson disease, and muscle dystrophy disorder, and of course, donor are checked for cystic fibrosis. Wilson disease is quite seldom, so we do not do it routinely. But when we have results of male, definitely the donor has to be matched and cannot be a carrier. So genetical matching is performed at IVF Spain when we are aware what we are looking for. Blastocyst culture, it's a basic step in reproductive medicine when we want to offer you certain embryos quality and certain pregnancy rates. In egg donation, day 3 embryos have a lot lower success rates than day 5 embryos. In IVF Spain, we not only offer you one blastocyst, we offer you 3 or 5 blastocysts. We do not want you to take this risk. Some cycles of donors go very well. We can generate at once 3, 5 embryos. Some cycles do not go that well, and then the clinic has to stimulate a new donor for you without any extra cost to fulfill this 3 to 5 blastocyst guarantee. So summarizing, to younger ladies that are listening to me, I don't think that there are many, but somebody under 35 years old, this is the moment where we should think about having our first child. If not, we should think about freezing our eggs. I hope one day AMH testing will be performed in offices of GPs, and GP seeing that your AMH is low will be sending you to specialists for reproductive medicine right away without wasting time for inseminations from 35 years old onwards. If your AMH is still good, I would recommend an IVF cycle with genetical testing of embryos. So I know one blastocyst has 70% chance of developing a positive pregnancy test and 60% chance to develop with a healthy baby. So if we play smart at the age of 35 years old, we're gonna have 20 eggs, 5 euploid embryos, and family planning. These numbers are not that promising at the age of 40, 42, but still it's doable before 41 when we work double, when our AMH is less than 2, perform embryo banking and plan our family. If we are older than 42, the situation becomes very difficult, and then egg donation is the smartest solution that we can offer you. Thank you very much for your attention.
Thank you a lot. We can then jump to the questions. Let's have a look. First question is from Lisa, and it may be a difficult one. Hi, I have 2 boys conceived via embryo donation abroad. I'm from Scotland. Without access to fertility treatment in Europe, my 2 beautiful sons would not be in the world. I now support others on a fertility journey. I wondered if Brexit would have an impact on UK citizens seeking treatment in Europe, and what changes, if any, Brexit might bring. Thank you, Lisa.
Lisa, thank you for this question. I came back to Europe 20 years ago, and I have seen Europe. I came back from Detroit back to Europe 20 years ago, and I have seen Europe going a very positive change and losing borders. I hope that even though we're gonna have Brexit, but medicine will stay Without Borders means when you need a specialist, you can, come to IVF Spain anytime. We will counsel you like everybody else. And as an American citizen, I remember I could stay in Europe only 3 months. Even though you will be like out of European Union, you'll be able to stay in Spain for at least 3 months. So in these 3 months, we can plan not only one cycle, at least three. Okay, so for us to organize your treatment, it wouldn't be a problem. Financially, we expect that after Brexit, pounds will go down. So this could be an issue, but anything else, I believe in medicine without border that we should have the everybody independent where you're from, which language do you speak. You should have the same access to good specialists. So I hope Brexit is not going to affect our communication and work in medicine at all.
Thank you, and hopefully it will be just as you said. The next question then, I have a question. Does gluten intolerance makes poor egg quality or implementation failure?
Okay, gluten intolerance, there are no evidence-based medicine papers published about gluten intolerance and egg quality. A recurrent implantation failure, three factors: eggs quality, your endometrium receptivity window, and immunology are important. Gluten, there's nothing published that I'm aware of that can have an impact either on eggs quality or implantation.
Thank you. And the next question is, do you have Skype consultation, and how much does it cost?
Okay, of course we have Skype consultation. I cannot imagine somebody traveling from the United States, Canada. We have also patients from Sydney, Australia for first appointment. Drop an email to Patients IVF Spain. We have nurses that are organizing our schedules and the consultation on Skype, the full consultation, 1 hour, where before seeing you, you send to us your history form, all the results. So the doctor has time to read it before the Skype and prepare. This kind of consultation is about €150 now. Drop an email to patients, and we'll be more than happy to focus on your case personally.
Thank you very much. And let's see the next question. So you only recommend PGS for ages 35-42. Over 42, you recommend egg donor. Why?
I'll answer this question right away. Coming back to the other question before, we are regularly in UK. On the 12th, 14th of April, we will be in London, UK, on the Harley Street 39. I'll be having consultations there, free consultations, mini consultations, okay? And we will be regular now in London once a month. I'll be flying to see patients. So if the Skype, is not convenient to you, let's meet in London and we can discuss your story in person. But drop an email to patients so the nurses can schedule you for this mini consultation. We can make it happen in a week, basically. Now, PGS. I used to work before in German medicine in Berlin, and pregnancy rates without genetics between 35-42 years old are too low to recommend not to perform it. On the other hand, in the United States, Doctors are afraid not to perform cycles without genetics, because if you miscarry genetically abnormal embryos, patient can sue you. Okay, so now the number of offices in the United States that performs genetical testing of embryos in the last 10 years doubled. Okay, so this is the approach that should be recommended. Over 42 years old, if you want to try with your own eggs, I'll be more than happy to support you. I had a lady from London, UK, 45 years old, Chinese background. We did IVF. She had an amazing ovarian reserve, and we had one genetically normal embryo. Yeah, we did. So, it's not only true in fairy tales, it happens. But it's like winning $1 million in lotto. If you believe it can happen to you, I'll be more than happy to support you. Statistically, ladies 42, 43 years old, it's super difficult to find genetically normal embryos. And this is the age where we recommend egg donation. If you are not ready psychologically and you have a lot of IVF cycles which were unsuccessful, please consider IVF and genetical testing. If you have genetically normal embryo, we bring you to pregnancy rates of somebody who is 20, 30 years old. If all the embryos are genetically abnormal, then you know why it has not been functioning, it has not been working in your case, in your country.
Thank you for explaining that. And the next one, the embryos suffer at the biopsy. If a woman over 35 only have, for instance, 5 embryos, is it not better to introduce that embryos without TGP? And then if the woman is pregnant, analyze the DNA in the maternal blood.
Wow. And what if the maternal blood comes out with the trisomy 13, 18, or 21? Can you imagine yourself being a consultant and recommending your patient an abortion? Or how would you try to walk in my shoes? Okay. I've been working in Germany, and genetic testing was not possible, and it's super difficult to counsel, a patient after IVF treatments where genetically abnormal embryos were generated. So I prefer to do my job upfront, and embryos do not suffer if they're biopsied. The study that was introduced 20 years ago of Professor Masterbrook et al. It was the Dutch study from University of Amsterdam, was showing that if you biopsy embryos on day 3 of development, embryo has just 8 cells, you destroy 20% of this embryo. So the success rates are going dramatically down. Okay, and we had to wait 10 years for better studies from the United States, showing that if you biopsy blastocyst, the pregnancy rates per transfer are 70%. Now, transferring fresh or frozen, Professor Shapiro, Las Vegas, was the godfather showing to medicine that it's better to freeze embryo after a cycle. Why? Because the endometrium, when it's growing, during the IVF cycle, you produce a lot of hormones, a lot of estrogens. The growth of endometrium is not physiological. So we have higher success rates with frozen genetically normal embryos put to patients in natural cycles after IVF. So when we perform IVF PGS cycles, is first step, generate eggs and embryos. Forget about endometrium that is growing in a bad, unphysiological way. Freeze the embryos, see which one of them is good one, and in the following cycle, grow endometrium in the physiological way. Can be natural cycle or substitute cycle with progenova. And with this approach, first step, IVF PGS, embryos frozen, transferring in the following cycle, we have a lot higher success rates than in fresh cycles. It's what it is.
Thank you a lot. And the next question. I am 32 years old. ICSI cycle to grade 1 embryos transferred. Resulted in ectopic pregnancy. Second cycle, 3 embryos, but failed to progress on day 2. I would like to try another own cycle. Is there anything to improve number of eggs with low AMH?
Low AMH is a problem because it shows me your ovarian reserve at all. It shows me how many eggs per cycle you're going to generate. The dose of hormones that you're going to receive in the next cycle has to be adjusted to your AMH. Sometimes, patients with low AMH have a lot better cycle with a low dose of hormones than with high dose of hormones. And then you should think about day 5 culture, blastocyst culture. If we see that blastocyst culture cannot be achieved, that there's no blastocyst, then slowly you should allow yourself for egg donation. In IVF Spain, in this kind of situations, when we have somebody who's 42 years old and we develop blastocysts, beautiful embryos, we recommend something called embryo banking natural cycles. Means when I know your AMH is low, I cannot give you high dose of hormones to receive eggs because I'm going to block the ovaries. We give you a low dose, middle dose of hormones. We grow 2-3 eggs in one cycle. We develop to the blastocyst. We biopsy this blastocyst. Embryo is frozen. One embryo out of one cycle. We repeat this kind of cycle in 3 months. There are some women doing embryo banking natural cycles for a year. And then, but you have to have blastocysts in the first cycle. Okay, we only allow you for embryo banking natural cycle if you have a blastocyst. Yeah, and then if we find genetically normal embryos after this kind of project, they are transferred in the next cycle. If we see after first cycle, there's no blastocysts, yeah, means X quality is poor, we cancel you for egg donation.
Thanks a lot. And let's take another one. Also, I believe that you say that you recommend genetic tests in women that are over 35, but do you have an age that is obligatory to do PGD or PGS?
Okay. Believe it or not, sometimes in IVF Spain, we do PGS cycles of ladies that are 27 years old. Why? Because what can I do? If somebody had 3-4 cycles in their home countries and there are no successful pregnancies, I have to find out why. So reproductive medicine, we have to see stepwise. The first step that people undertake, because insurance companies are unfortunately paying for this, are IUIs. The second step is IVF. Unfortunately, in majority European countries, insurance companies pay for day 3 cultures. Pregnancy rate 20%. What IVF Spain can do? We can do better. We have to recommend blastocyst culture. We have to recommend genetical testing because this is the most sensitive embryo selection. And sometimes when you have somebody who's 27 years old and she generates me beautiful embryos, but she has a very bad endometrium, my first step of work with you is concentrated, is focusing on generating genetically normal embryos and then growing your lining. In one cycle that you are offered in your country means IVF and transfer fresh. It's not doable. It's not doable to focus on 2 things at the same time properly. So Routinely in IVF Spain, everybody who is older than 35 years old receives PGS testing. Not obligatory, recommended. If somebody comes to us and is younger and has recurrent implantation failure, we recommend PGS testing, of course, too, because we want to do something better. We cannot repeat all the time protocols that were unsuccessful, because we have to change something to, to talk about solutions, to give you different opportunity.
And thank you for explaining this. And the next one, in the slide about embryo banking and PGS, the patients need to have the 3 indications that you say, or only one to take part in the embryo banking and PGS?
Embryo banking is super straightforward. Indication is low AMH. You do not generate me a lot of eggs. The cycles that we like in reproductive medicine are 16-20 eggs, 8 blastocysts, depending on age, number of genetically normal ones. When we see that your AMH is lower than 2, you will never generate me 20 eggs. You will generate me less. So this is the first moment where we indicate embryo banking. There are some patients that, even though they have high AMH, but the sperm quality of a husband is poor, and then they do not generate me 8 blastocysts, they generate me 2-3. Then in 2-3 months, you are coming back for embryo banking for 1 cycle more. So when do I decide embryo banking? When I have AMH lower than 2, when outcome of the first cycle is not completely satisfying me. And if you say, listen, I want to have more than 1 child and I have just 3 blastocysts, yeah, so then we can do family planning even though you have low AMH.
And thank you. Let's check the next one. Is the success rate of egg donation independent of the age of the patient?
Yes, ma'am, it is. Egg donation success rates are the same when you are 35 years old and you are in premature ovarian failure, or you are 50 years old and you are in your natural menopause. So as long as your uterus is working, as long as you do not have any anatomical abnormalities like fibroids, polyps, clotting issues, your pregnancy rates are 70% with blastocyst. For transfer, age independent.
Yes, and straight to the next question. Besides AMH, what other tests should we do to see if using our own eggs is possible? I'm 45, sorry.
We should do a cycle, because if your AMH is low, but you develop blastocysts, and on top of this, you develop genetically normal one, wow, you can be pregnant with your own eggs. Means AMH tells me about a number of eggs which we are going to generate. But I have to see it in the lab to tell you if your eggs quality is good enough to develop with a blastocyst and you have a chance to be pregnant with your own eggs, or your AMH is low. It's okay. You're not going to generate many eggs, but maybe the eggs are so strong that we have at the end, after 5 days, culture blastocyst. Yeah, so you have to do a cycle to see if it's doable with your own eggs or not.
Thank you. And the next question is, AMH are involved in oocyte quality in women under 30?
No, AMH tells me only about numbers. How many eggs you want to generate me? Yeah, AMH, the cycles that we have, it's not published, yeah, but I can tell you. AMH more than 2, we expect more than 20 eggs. AMH between 1 and 2, 10, 20 eggs, usually 15, 16. AMH under 1, less than 10. AMH less than 0.7, 0.5, very poor results. So AMH tells me just about numbers. How many eggs potentially you're going to generate me. The numbers that I told before here were with antagonist protocol with 225 units of gonadotropins.
And straight to the next question, thank you for the previous one. For what reason the percentage of normal blastocyst is more when patients have 7 to 10 embryos instead of 4 to 6? The number also affects the quality?
It's super easy to answer. Statistically, the more embryos I have, the higher probability to find genetically normal ones. So basically, when we have young girls, like 35 years old, I just want 6 blastocysts because I know that 3 of them are genetically normal. But when I have somebody who's older, I need more eggs, more embryos to find genetically normal ones. The number also affects quality. No, the number does not affect quality. The number affects statistical probability to find good embryo in somebody who is over 40 years old.
Thank you. And now the long one.
Oh, wow.
I am 42 years, going to be 43 in May. Diagnosed with PCOS. MAH level is 16. I had 2 failed IVF cycle with own egg. First treatment retrieved 10 eggs, 8 fertilized, 5 reached blastocyst, but only 1 was good to transfer. But 2 was eventually transferred, but no pregnancy. Second treatment, there was no down regulation, so cyst developed, which affected egg growth, but consultant carried on and eventually 2 eggs retrieved. Egg quality very poor, so no transfer. I started metformin 6 months ago, 1,500 milligrams reduced to 1,000 milligrams last month. Considering another IVF, should I use my own eggs again or should I go for egg donor? Many thanks.
You break my heart. This kind of medicine that you are quoting here, we used to do 20 years ago in IVF Spain. I know protocols with PCOS, use of low dose of gonadotropin, stimulate 2-3 follicles, and see what happens. In IVF Spain, we developed our own protocol for PCOS, where with this high AMH, you can be an egg donor, madam. So I have to treat you like an egg donor. I will give you middle dose of protocol antagonist, so I'll never hyperstimulate you. And I expect out of you more than 20 eggs. These eggs usually do not fertilize well. We have to be aware that if we have good eggs quality of good donors, the blastocyst rate means number of day 5 embryos is 50%. With you, with PCOS, number of blastocysts will be 30%. But no worries. When you generate 30 eggs, I expect 10 blastocysts of somebody without PCOS. You with PCOS, I expect 6, 7. And then, I do not know how old are you. I 42 years old. In your age, 10% should be genetically normal. Okay, means out of 8, maybe 1, 2 will be good ones. Yeah, so you have to psychologically allow yourself for a total different approach. Like close the book, the classical book of reproductive medicine with low dose metformin, because it's not working in your case. Okay, in this kind of cases like yours, we perform IVF with genetical testing of embryos, and then we focus in the first step of embryo generation process, day 5, blastocyst culture, biopsy, freeze, and then in the next cycle go back for the transfer. So if we see that we generated a lot of eggs in your case and there are no blastocysts, means due to your age, even though you have an amazing number of blastocysts, you have an amazing number of eggs, but we cannot grow them to the blastocyst, then I'll tell you that you should do egg donation. But before egg donation, with this AMH, I would fight for your genetics till the end.
And thank you for explaining that. Next one. In early 30s, is it worth taking coenzyme Q10 to improve egg quality?
Yeah, it is worth taking. There's an Q10 is FDA approved, and yeah, there are some papers published showing that DHEA Q10 have a positive influence on egg quality.
And the next one, I am 39 years old, had 3 failed IVF cycles with my own eggs. I am thinking to go to egg donation. Do you think I should try with my own eggs? I feel tired of being disappointed, but I do not know if this is correct decision. None of my IVF cycles I did PGS test, so I do not know about the genetic of the embryo, but I have blastocyst.
Okay, this that you had blastocyst is already very good news. Okay, I would like you to come to IVF Spain, and I would like us to see your ovarian reserve, your age, AMH, and antral follicle count. Please send us the protocols and pictures of embryos that you had when you did cycles in your clinic at home. So, if you are able to develop blastocyst, we'll have to see what was the quality of the blastocyst. If the blastocyst quality was AB, we will be more than happy to do one IVF cycle more with you with genetical testing. If blastocyst quality that you had was C, you show us pictures that we're not going to like, that embryos are not going to fulfill criteria of a good blastocyst, then we should do a donation. So please drop an email to patients, and we'll be more than happy to counsel you either on Skype or in London next week.
Thank you, Dr. Natalia, for this answer. And the next one, do you recommend PGS with egg donation cycles?
It's a tricky one. I do recommend, because I have done more than a lot egg donation cycles, and I've seen miscarriages with genetically abnormal embryos of egg donors. It's not something done routinely. We have to be aware that euploidy rates between centers differ. In IVF Spain, we have 80% pregnancy rate with egg donors, so we do not recommend it routinely. But PGS is the most sensitive for embryo selection, and I think in the future is going to be a standard procedure.
And I think that this one may be a little similar. When would you recommend PGS with egg donation? So
Yeah, so in IVF Spain, we perform a PGS to make time to pregnancy as short as possible. Basically, second egg donor or somebody coming from different clinic with egg donation unsuccessful in a different clinic to make patients parents as soon as possible. And as I say, psychologically, I prefer to do PGS cycles because then I know we have done our best.
yes, and the next one, thank you for this. We have 2 recently failed embryo transfers with PGS normal egg, aged 40th time, now 41. What would you recommend as we found our own normal eggs?
We have to be aware that after so many cycles, sometimes embryo is coming to the womb and endometrium is not receptive. So we recommend the uterus lining biopsy. Yeah, we recommend come with the catheter in a substitute cycle, day 21, do the biopsy and send the biopsy to us to see if you need 5 or more days progesterone to open implantation window. We have one office in central London who is performing this kind of biopsies for us. We have basically a service all over UK who performs this kind of biopsies for us. So if you would like us to design this kind of cycle for you, so you know when the biopsy has to be done, drop email to patients, and then I'll be more than happy to draw this kind of cycle for you, so you know when the biopsy has to be taken, and we'll inform you who in UK will do the biopsy for you.
Thank you for the answer and the question as well. And let's see the next one. Is it possible to flight after embryo transfer?
Madam, we have patients that fly after embryo transfer to Sydney, Australia. So the most important thing after transfer, do not work hard, no bathing, no swimming, no underwater activities, just showers. You do not use tampons, only pads, no bicycle, and no sexual intercourse. So these are the most important things. Every patient after transfer to IVF Spain has Clexane injections. So a lot of our patients are flying home the same day.
Great to hear that. And the next one, do you have egg donation programs with PGS? How much do they cost?
Exclusive egg donation plus it's 10,000 euro, and PGS it's 3,000 euro on top. Of course, we have egg donation PGS programs. We were the first clinic in Europe that introduced PGS to egg donation 5 years ago.
Okay, thank you. And the next question. Hi, I've just had a 4th failed cycle of IVF ICSI. I have never been pregnant. Is there anything you could suggest to understand why it consistently fails? I've had 2 full steams, Clomid banking, and a naturally supported cycle.
Yeah, so I have to know how old are you, and then I have to know what kind of cycles you had before, what kind of hormones were you given, if you had blastocysts or not. The key is euploid blastocyst. Yeah, if we are able to generate euploid blastocyst, you have 70% pregnancy rate per transfer to be pregnant. If not, then we have to speak about egg donation. So the wise thing is drop an email to patients, IVF Spain, and then arrange for a first appointment to see your age, AMH, antral follicle count, to see your ovarian reserve. It's like ABC of reproductive medicine. 3 A's: A's, AMH, antral follicle count. And then when we see if it's doable to work with your own eggs, if the numbers are on your side, then we can propose an IVF cycle with genetical testing. If we see that the numbers are totally against you, then we have to speak about egg donation.
Thank you a lot for explaining that. And the next question. I was made to understand that a bulky uterus due adenomyosis should be treated, that is, to shrink the uterus before egg donation treatment.
Okay, bulky uterus and endometriosis. Of course, we don't regulate patients. Basically, we put you artificially into the menopause that you do not produce any hormones on your own. You do not like us for this kind of treatments because you have side effects of not having estrogens in your body. So the bulky uterus we can treat 1-2 months through downregulation. Then we should do a test cycle, oral estrogens, day 10 scan to see how thick the lining is, to see which dose of hormones you need to grow a proper lining. And then I know if I repeat it or modify it in the transfer cycle. And then bulky uterus should not be a problem. Endometriosis is an immunological issue in reproductive medicine that can be treated with prednisone.
Yes, and straight to the next one. I am taking metformin 1000 milligrams, fish oil 1000 milligrams, folic acid 400 UE, ubiquinol 300 milligrams, calcium 800 milligrams, ovacitol. I have PCOS going to 43 next month with poor egg quality and MAH 16. What can I do to improve egg quality?
Madam, you are doing already a lot to improve your eggs quality. Um, if you want to see that you are able to generate genetically normal embryos at the age of 43, please drop an email to patients, come for the first consultation, and then let's do one cycle with genetics. Let's see if with this cocktail of medication that you are taking, are you able to develop euploid blastocyst? If yes, the chance that you'll be pregnant is 70% per transfer. If we see that it's not doable, that X quality is poor, we do not have blastocysts, so they're all genetically abnormal. You have a piece of evidence in your hand, piece of paper showing you that we should do a donation, okay? And it's easier for you when you see that there's no blastocysts or everything's genetically abnormal, it's easier for you to take this decision.
Great, thank you. And the next one. I have severe endometriosis, which has had a huge negative impact on my egg quality, only discovered when my IVF cycles have failed. How do you ensure that your egg donors do not have similar issues?
No, donors cannot have endometriosis. They all have AMH more than 2. They have good young eggs quality. In order to run egg donation clinic well, I have to show certain quality. I have to show certain pregnancy rates, and then if we do one cycle with the donor and the eggs are bad, we do not generate blastocysts, then the donor is cancelled. The donor cannot work with us anymore. And the good thing about IVF Spain is that you sign not only the certain number of eggs, but you sign protocols with a certain number of embryos behind. So if you're coming, we do have donation. Eggs are poor of a donor because of endometriosis of any reasons, any other reasons. There are some young, beautiful, healthy women that generate bad eggs. But I inform you, madam, we have nothing to transfer, but you signed a program with a guarantee of 3 or 5 blastocysts. We have to stimulate a new donor for you without any extra costs. So this is how it's solved.
And thank you for the answer. And the next question is, does it happen that AMH dries?
I wish it could happen. I've seen it a couple of times in my life. I've seen it by patients that are treated with methotrexate because of autoimmune issues that with the age, they are young, okay? Autoimmune diseases happen to young women. And then after methotrexate, is a medication used for chemotherapy, but also in low dose in autoimmune diseases. And then after methotrexate, you not only feel bad, weak, but also your AMH is low. And then after 3-6 months, your AMH can recover. So this happens super seldom. Basically, if we have somebody without autoimmunological issues, without taking this kind of medication, with the age, your AMH can only go down.
And thank you for the answer. And the next question, I live in Norway. Do you have cooperation collaboration with any doctors in Norway? I know many people here in Norway seek fertility treatment.
You know what? Thank you so much for this support. Usually before Christmas each year, key people in the company sit down together and decide where we are going to travel in the next year. Where are we going to grow our patients that need us? I do not speak Norwegian, so I never thought I could have, potential patients in Norway. But if you tell me that it's worth it to organize patient meeting in Norway, I'll be more than happy in 2020 come to Norway and talk to patients about IVF, about PGS, about egg donation. I do marketing development in IVF Spain already 8 years. I think Norway potentially next year could be on our map. I'll be more than happy to do it. Collaboration with somebody in Norway, not in this moment, but how collaboration happen between clinics is through patients, that you receive patients from this part of the world, they're happy with you, they talk well about you. You start sending patients to do ultrasounds near their home. They bring you names and addresses of doctors that treated them, and then you just have to meet them. So yeah, if you have a feeling IVF Spain should grow in Norway, let me see the market studies this year, and then definitely next year we can discuss it.
We have a continuation, so I will then jump to this one. There's a clinic in Russia that comes to Norway almost every month to collect patients, but I prefer clinics in Europe, so please come to Norway. Yeah. Thank you for the question and for the answer. We will be slowly finishing, so if any questions, just type them in. But the next one, can donors have PCOS?
No, the donors cannot have PCOS, but the donors can be high responders. Okay, now let's review the definitions in medicine. High responders, somebody who has high AMH, you do transvaginal scan, you see more than 12 follicles in antral follicles in each ovary. You know this lady, when you treat her with a middle dose of hormones, is going to generate you more than 30 eggs. So that's why your goal in egg donation is to give her high responder, lower dose of hormones, so you receive at the end 20-25 eggs. Okay, so this is the story of high responders. PCOS. I don't remember when, but it was an ESHRE, European Society of Human Reproduction, in Rotterdam a couple of years ago. And ESHRE developed something called Rotterdam criteria to define somebody PCOS or not. 3 criteria. High responder means transvaginal scan and 12 follicles. Hyperandrogenism means secondary characteristic with acne, with hirsutism, that is due to testosterone with an ovarian background. So the adrenal hyperandrogenism has to be excluded. And number 3, FSH-LA ratio is 2:1. So it's upside down. So when you have somebody with this criteria, you define somebody PCOS, and definitely donors in IVF Spain cannot be defined as PCOS.
Thank you for the answer. And let's see the other one. Does quality of sperm affect embryo quality? If so, what can be done to improve this?
I like this question a lot because we talk a lot here about female factor and we forgot male. What can be done? We have some bad sperm analyses. How do I say good or bad? There are World Health Organization criteria 10 years ago reviewed. We have to focus on volume, concentration, motility and morphology, okay? And then I defined somebody's normal zoospermic, everything okay, asthenozoospermic problems with motility, teratozoospermic problem with morphology, azoospermic, no sperm, cryptozoospermic problems with motility and morphology. You can imagine that in IVF Spain, we focus on good quality of embryos. So I want to have blastocysts. I want to have genetically normal blastocysts. So if I have somebody who has bad sperm result, what do? I do your karyotype. I have to make sure that you are genetically male. I have seen bad karyotypes and bad sperm results. Bad karyotypes means you are a carrier of balanced translocation, and that's why your sperm analysis is bad. And then you need genetical testing of your embryos if you are 20, 30, or 50. Okay? Karyotype. Then, if there are, not major issues, we recommend vitamins, high ejaculation frequency. This is something that boys like, sex twice a week. We let them sign it, okay? This is what your doctor recommends. The more often you leave the sperm sample, the better quality you have it on the day of egg retrieval to fertilize. And then again, the classic book of reproductive medicine has to be closed. Because there's a lot of centers that recommend an abstinence before leaving the sperm sample over 1 week. And then I do not want to see the sperm results. I do not want to see them. The sperm cells have bad morphology, they have high apoptosis, and they have very high fragmentation. So in IVF Spain, abstinence is just 48 hours, 2 days before fertilization, okay? Major andrological issues, okay? We do not only do karyotype, we also do carrier screening for cystic fibrosis, because we know that cystic fibrosis goes with some sperm abnormalities. With azoospermic patients, we test for there's a gene called AZF, and we also do hormonal studies. When testosterone is low and FSH still allows us, there are some men that put injections to improve sperm quality, the number of sperm cells. Yeah, so andrology is fun, but you have to know which direction you go. So first is always genetics. First is karyotype, cystic fibrosis, then hormones, and then treatment, depending on this, what results are showing us. If everything is so bad that we did a cycle, somebody is a carrier of balanced translocation, all embryos are genetically abnormal, then the solution is sperm donation.
Thank you for the answer. And let's see the other one, which clinic in UK performs endometrium receptivity biopsy, and is it sent back to Spain for testing?
There is an office on Harley Street. Dr. Karoshi does this biopsies for us, and also Karoshi does it for Central London. IVF Matters does it for other parts of UK. We design a cycle, means you have to be on 15 days oral estrogens, 5 days progesterone. So day 21 of the cycle, the biopsy has to be taken out, and then IVF Spain, with collaboration with IVF Matters or Central London, Dr. Karoshi organizes a transport courier to Spain. We work with EGLS lab, and this lab gives us an answer if you are receptive or not. Drop an email to patient if you want us this cycle to be designed for you.
Great explanation, thank you. And let's check the next one. Is there any treatment for endometriosis when doing IVF cycles?
Okay, endometriosis is a headache when we do egg retrieval and we have chocolate cysts. Endometriosis is something that is taking eggs out of a good ovary. It's taking the space, so you are losing your AMH. So the treatment for endometriosis out of IVF is long cycles. Means you have to take birth control pills and have one bleeding or two bleedings annually. Means you do not have your period. What is endometriosis? Is endometrium that probably through the retrograde menstruation came to your belly and is growing in the ovaries, in the tubes, in the belly, inside, okay? So we have to do everything that endometriosis, that this retrograde blood that stays in your belly does not take a space out of ovaries, that does not make your AMH go down. So this is when we talk about eggs. Now, transfer. Endometriosis for us is an immunologic factor. Bulky uterus should be treated with a downregulation for 2-3 months before a transfer, and every patient in IVF Spain after a transfer receives prednisone, because endometriosis is seen as an immunological factor.
Thanks a lot. We will be slowly finishing, but we have 2 questions more. Hi, what drugs do you use during stimulation? In the UK, I was given high-dose Menopur 450U. Thank you.
Melody, I have to answer this question out of line. I cannot tell you which medication we use in IVF Spain, because of law in pharmaceutical companies. I can only tell you that it's a mixture of FSH and LH, and there are 2 medications that have it. That contain it. One is American, very expensive but very good one, and the other one's Italian. And I think that I already said more than I should.
Thank you for the answer and explaining this. And the next question. Is there some sort of age limit for men to produce good quality sperm, as it is for women with good quality eggs?
The answer is no. Men can have children a long time. The oldest father that we had in IVF Spain was 85 years old, was from London, and I always, do a lot of sports, especially jogging, marathons, half marathons, allow you to disconnect. And I remember this father, after becoming a father, we met half marathon in Las Vegas, night marathon. So it was a very fit father, even though he was 85 years old. So the answer is that when you have good eggs quality, the age of a father doesn't matter. We have a different problem. The problem is low testosterone and issues with erection. So the sperm is good, but sometimes due to your age and problems with your vessels, you can have erection issues. And then if there are no contraindications, we recommend oral medication to improve erections. Yeah, so this is the answer to your question.
And thank you very much also for the story about the father. I checked the Q&A session in the chat, and we don't have any more questions, so we will be finishing. And thank you a lot for your participation, everybody, and for the presentation, Dr. Natalia, and for all the answers you gave us for the questions. Tomorrow on our website, you will find the recording from today's webinar, and you can watch it again. You can share it if anybody needs to watch it also, and have Dr. Natalia explaining all those important things. And Dr. Natalia, do you want to add anything?
Thank you very much for listening. Thank you very much for questions. I have a feeling that the more often we see each other, and we see each other once a month now, the more interesting questions I get, that the knowledge in you is growing. So if you want to discuss something with us in person, please drop an email to patients@ivfspain.com. If not, you have a feeling you want to study more yourself, please watch us next time with the next webinar, which also will be very interesting. Thank you very much for listening.
Exactly. And if you also didn't ask questions and you maybe wanted, exactly, just throw an email. And even if you write at our email, we will forward this to Dr. Natalia and IVF Spain. So feel free to contact us. And I can't wait for the next session with you, Dr. Natalia. So I'm happy already. Okay. We will be finishing, and I wish you all a very good night. And by the way, I hope that we can see each other next week on our upcoming webinar. I hope to see you all. Thank you again, Dr. Natalia. Thank you all. Have a great night and see you soon.
Thank you.
Bye.